Hello, everyone. Welcome back to Neurospicy Nursing. A little bit of a different audio quality here, in the process of moving. So my new mic that I got is packed up and ready for me to move tomorrow morning at like 7 a.m. So yeah. But anyways, today we're going over pediatric musculoskeletal disorders. So let's get on into it. All right, so kind of starting with the basics, just to kind of go over it. Tendons connect muscles to bones, ligaments connect bone to bone or bone to cartilage. And because they have low blood supply, they tend to heal a little bit more slowly. Muscles come in what I like to call two different flavors. You get the smooth muscle, which is involuntary, and the skeletal muscle, which is voluntary. Kids, like we've talked about in the past, are not just small adults. They're constantly growing, which means they heal fast, but also that rapid growth can cause injuries. And for kids, because they're again growing, the growth plate itself, since there's a lot of active cell division that's happening, it's super sensitive, especially to like hormones and whatnot. And the periosteum, it's a little bit thicker and stronger in kids, which helps prevent displacement. But as we get older, it can displace. All right, so injury impact and developmental stages. So the first thing I want to just kind of make you guys aware of um, is that, again, growth plate injuries, they're going to matter because they can end up causing long-term limb lengthening issues. Kids are all around a little bit more pliable, and they technically need more force to injure, which is why they get fewer sprains and dislocations in comparison to adults. But since their bones are still growing, it can be kind of easier to break a bone. All right, into infants and preschoolers. Infants and preschoolers are mostly cartilage, which is why I kind of gathered them together. Infants specifically have soft cranial plates. They grow through moving their body and stimulating those muscle fibers that they have. Toddlers, especially, are going to be super wobbly, as well as some preschoolers, wobbly, clumsy, because they're still trying to develop their coordination. School age kids are still clumsy, but they've improved significantly. Their bones have hardened, but not full, they haven't fully mineralized yet. Teens, we're hitting another rapid growth phase at this point. Their bones are growing faster than their tendons. So you end up seeing something called Osgood-Schlatter disease or Sever's disease. There's a lot of tendinitis and stuff like that they can have as well. Their hands and feet are going to grow really fast, so they also can be uncoordinated. All right, so going into our nursing assessment is going to start off with all of the growth and physical findings, like what we just talked about, like tracking their height and weight on growth charts, watching for any percentile drops, assessing their gait, their posture, if they have symmetry. We're palpating their joints, we're checking their range of motion, looking for pain cues, checking temperatures, swelling, and bilateral strength. All right, for the systemic assessment, it's going to include, your normal ABCs, vital signs, eyes and nose, and your neurostatus. If they have had a broken bone, we're doing neurovascular checks like sensation, temp, cap refill, pulses, and any movement distal to the injury. I also wanted to bring up the 5Ps, which is how we know that there's been some sort of neurovascular compromise, which are pain that's been unrelieved by narcotics, pallor, pulselessness, paresthesia, and poikilothermia. So you will see this if they have a cast. Let's say the cast is like way, way too tight on them. And like the swelling is just overwhelming the cast, that could be a reason why you would see the 5Ps that are leading to that neurovascular compromise. All right, so interventions and cast cares, big bold letters here at the top. We are teaching them do not scratch underneath your cast with any object. Do not stick anything into your cast ever at all. We're not sticking anything inside of the cast at all. If they've had an acute injury, if it's like a spinal or a neck injury, obviously we're going to stabilize them, stabilize their head and neck specifically. But any extremity, we're going to elevate it. We're going to ice 20 minutes on, 20 minutes off, keep it warm. Specifically the child, keep them warm. Um, and then we're going to encourage movement in the unaffected extremities. That kind of just helps with blood flow and stuff like that, right? We're not going to just tell them to stop moving at all. We still need movement. And if they've had a pelvic fracture, we have to make sure that we're watching for hematuria and shock. For skin and mobility, we are making sure we're using those, if we're using those overhead trackies for positioning, they need a foam mattress just to help with their skin. And then we're always assessing around the cast and any splints. If they have any, like if they have a halo device, you're checking the pins as well. Or if they're in like bugs traction, like any sort of traction, you're checking pins and stuff like that. So skeletal. If they're in skin traction, you're checking around the like usually well, I've seen like a tape type thing. So you're checking around like the tape. Anyways, just check around any area that has something that's not their skin. You're just looking for any irritation and redness. You guys know what I mean. And then cast care, we're keeping the site clean, removing any pressure points, using moleskin if there's like rubbing. If it's itchy, we're going to use a hair dryer. You can use it like they could put their arm in a freezer, or obviously take antihistamines. And then for cast removal, it can be very, very overstimulating for some people. So make sure that they know the expectation that it's kind of noisy and it vibrates really aggressively, but it's not going to cut them. All right, so this is the rapid fire pathophys of all the conditions for the musculoskeletal system that you're going to need to know for your test and sprinkled in with some of the treatment stuff. For club foot, it is an inward and downward drop of the foot. Treatment is going to be serial long leg casting, long-term PTOT, and sometimes they may need a heel cord tendinotomy. If they have like calves perthes, it's for the femoral head has become necrotic. It's going to happen in ages 2 to 12. Treatment is going to be surgery. They'll have an abduction brace, traction, and they'll be non-weight bearing for a while. If they have developmental hip dysplasia, this just means that the femoral head doesn't fit in the acetabellum. So they'll have Barlow and ortolani click, which is it's just like a sound that you hear when they're like walking. Treatment is gonna progress from the Plavix harness to the spica to the surgery. Don't forget when they have the harness, there's a bar like in the middle. You can't grab that bar. That's for stability. You're gonna grab like them by their hips, right? Not by the bar in the middle. Okay, juvenile arthritis. It is inflammatory with remission, and they have exacerbation cycles. I actually grew up knowing someone who had juvenile arthritis on my swim team, and his relapsing remitting was got so aggressive to the point where one, he was obviously on like DMARD medications, like as mentioned here, um, but he also swam in like a full wetsuit. So then when we went to competitions, he would be so fast because he had no drag. It was crazy. Anyways, I digress. Management is going to include DMARDs, NSAIDs, prednisones, and then for pain control, sometimes maybe you can see opioids, not super common anymore. But opioids obviously will do distraction, caregiver education, and then just checking the mental state of the child as well. All right, scoliosis. So scoliosis is going to be a C or an S curve. They're going to have if it's pretty severe, they're gonna have a brace and needs to be worn 23 hours a day. If it's even more severe where they just don't need bracing, like it's just so, so bad, they'll have a spinal fusion, PCA, and sometimes even a chest tube. And you can only roll them like a log. Hopefully that makes sense. Instead of going like having them curve up, you roll them side to side. Hopefully that makes sense. Okay. Osteogenesis imperfecta. In OI, you tend to see brittle bones, blue sclera, and fractures. Their teeth also look a little bit different. It's like their teeth look like they're almost like kind of transparent in a way. It's very interesting. If you don't know what it looks like, look it up. It's pretty cool. But management of this condition is obviously going to be safe handling because they're very, very delicate because of their brittle bones, PTOT, rods, and then supplements. In cerebral palsy, CP is going to affect the motor and sensory impairment. One of the most common ways to get CP is because of hypoxia, either while in the womb, during childbirth, or right after being born. So just keep that in mind that because of those things, these patients are also going to be high seizure risk. So you can see them on anti-epileptics. Sometimes Botox will help with the motor impairment, but for them, we're really going to prioritize skin integrity as well as fall prevention. All right, spina bifida is a neural tube defect. There's three different types: occulta, mengiocele, and myomengiocele. Myomengiocele is the one that has the sac on the back. Occulta is more just like the dimple on their lower back. If they do have the sac with the um, spinal cord in it, we're going to protect the sac and we're going to keep a wet sterile dressing on it, and that's going to be changed every 2 hours, and we can't put any pressure on it. So normally we want our babies laying on our back. Then we're going to try to lay them on their stomach just because it's going to keep that myomeniscus from rupturing. It's really like one of the biggest reasons why. Um, so no pressure on sac, no rectal temperatures. They are going to need a latex precaution as well as multiple surgeries. All right, here are the resources, and that's it. I also have a skin lecture that's coming out today. I'm putting these back to back because again, I'm moving tomorrow, and then I start my first new grad job on Monday the week after. So yeah, I was trying to think of like when I started. It's very close. It's like literally a week. So yeah. Um, thank you guys for listening, and I'll see you in the next one. Bye.